and we'll work through those questions this evening. So we are, and there is Dr. Williams. Hello, Kim. Thanks for joining us from the ER. We are so glad you're here.
Hi, Scott. I'm not sure if you can hear me. I've got no sound here, unfortunately.
Yeah, we can hear you very well.
It happens on occasion. And it seems to actually happen every other time that I do this. So actually, I think the more reliable one is actually my phone. So I'm going to try that one, okay? Can you hear me at all?
All right, sounds good.
No?
Yes,
okay.
We do.
All right, thanks.
The dedicated clinician, Dr. Williams, is in the ER this evening, but he's still joining us, so we're grateful. Hi, Kim.
Hi, Scott. How are you?
Good. We're connected. Great. Thank you.
Yep. So sorry it's dark. Susie is a little photosensitive right now, so we're keeping the lights out.
Yeah, we appreciate your time this evening, Kim. Thank you.
Okay. I'm not sure how long I can stay, but I'll try to contribute as much as I can.
No, we're grateful that you're here as long as you can. We thank you for carving out some time, even in the ER, for everyone. And Kim, I was just sharing with everyone that this, as you know, this was just kind of this is a invite-only conversation that we invited the people who had supported the journal and been a part of helping us launch this journal and create this amazing resource that we have today. So we have a smaller audience. We have 20 people. But it's a unique opportunity that we are giving them to ask you questions and to interact with both you and Colin. And so as we get questions, since we don't have a lot of time with you, I'll just throw those questions in as we go. And whenever you need to leave, you feel free to go, Kim. I'm just really grateful for your time.
Thanks.
So I thought what I would do is just start the conversation this evening with kind of three sections, both for you and Colin. I have some questions for you that I think will help to frame out our evening and at least even for me, kind of give me a little better understanding of, how research needs to move forward beginning today. So I'm always a student of history, and I know both of you are. And so I like to start with a historical perspective to try and understand how did we get here and what were the chain of events and decisions that led to the current circumstances and the current environment in healthcare, specifically in research. And then, from there, where are we now and what do we need to do moving forward to bring some change, especially in the field of lifestyle medicine and plant-based nutrition. And so contextually, looking back at the history of healthcare, I always think about healthcare as a system, just like a body system. And when we have, a major system failure, it's not just one thing that led to the failure, but it's a multiplied impact of decisions along the way. And so we have a system that's failing, as we all know. But what I'd like to do is just kind of start historically, and maybe I'll start with you, Colin, by just asking the question, how did we get here? How did we get here in healthcare? How did we get to this place where research is really focused, perhaps in many ways, in the wrong direction, but in also other ways in the right direction? I was just reading that, we have 28,000 journals and there's 1.8 million articles that are published every year. So there's no lack of research. But as we all know, there's a lack of research in the area of lifestyle medicine and plant-based nutrition, which is really looking at systems from a holistic approach and trying to understand how to work with a system in a synergistic way to allow the system to heal. So Colin, maybe you can start us off with a historical perspective of, how did we end up in the current place where we are in healthcare and specifically in research?
Well, thanks very much, Scott. My interest in history actually started many years ago. especially when I saw some of the pushback coming. I'm talking about 30 to 40 years ago, and became curious about, the extent to which, people were pushing back. I'm talking about institutions primarily. And so I had a chance at Oxford University, where I was spending a year at the time in 1985, 86, to ask the question, where from did our understanding of nutrition come from, as well as our understanding of cancer. Cancer is my other sort of research specialty. And so I found something really quite fascinating. Namely, in the middle 1800s, which in fact had roots in the 1700s, there was this view that cancer was a local disease. In other words, the surgeons preferred that interpretation. They said, "No worry, we'll just cut it out." That's very simple. The alternative view was that cancer is a constitutional disease, the whole body, if you will. And so that morphed eventually into the late 1800s, when the local theory of disease held sway over the constitutional thing. People were looking for, specific identifiable causes, if you will, eventually specific treatments. And so radiation came along as a possibility to kill these cancer cells, narrow beam.
Okay, before we start, we're trying to do the IV in blood. You want me to give you some of the meds? What they ordered was Zolfran, that's for nausea, give it to an IV.
I can't hear.
Then the other one is Tigan.
I'm sorry.
Go ahead, Colin.
Oh, okay. So the late 1800s brought forth the idea that focused beams of radiation might be used to kill cancer cells. They were considered deadly and not possibly treatable except for surgery. That in turn then eventually led to the idea that specific chemicals could be used to attack specific cancers. And therefore, get it that way, that obviously led to the chemotherapy notion, at least in the cancer field. So we had these two ideas, I say, local theory of disease versus constitutional theory. The local disease is modern day reductionism. The alternative, the constitutional thing, is, as you just mentioned, Scott, holism. Lots of things working together. I first became acquainted with my own research at the time, working with experimental animal model, where I was asking the question, why does animal protein have such a prominent promotional effect on cancer development, experimental cancer development? So I started looking for the mechanism. Being a student, if you will, the local theory idea, there's a specific mechanism. If we knew what that mechanism was, then therefore that could lead a theory maybe to one of these specific treatments. And this was research over a period of at least 12 to 15 years, I guess. A number of my students, doctoral students, postdoctoral students, who would look at one mechanism at a time. We were looking for one, we found one, then we found two, then we found three, on and on and on, lots of times within the same cell, or perhaps other cells elsewhere. And some of these mechanisms would increase in activity, some would decrease. But the really interesting thing was that as animal protein increases, increase in the experimental cancer we had in mind, it basically, it wasn't one mechanism. Every time we looked, and there were at least 10, 12, every time we looked, we found a mechanism that might explain the process. When all of a sudden it occurred to me, why am I still looking for the mechanism when there's so many? Then, thinking about it more broadly, it really morphed into the idea that all these mechanisms were working like a symphony, miraculously, which begged the question, what kind of forces are available to nature, if you will, to keep this such an order? Anyhow, I could go on and on about this, but what really struck me was this concept, everything working together. And the word that caught my attention was holism, but I had to put a W in front of it when I first published it, because I wanted to concentrate on, the architecture, the mechanism, the structure of the causation. And so I ended up with this idea of holism, which I would argue is nutrition. It's not about individual nutrients, really. It's about the whole food, all the nutrients working together, each of which have multiple mechanisms affecting broad outcomes. So nutrition became the victim of having chosen the local theory of disease idea, which that led us to think about specific causes and specific mechanisms and specific treatments, if you will, very focused, and that led to the pharmacologic approach. Alternatively, nutrition is not that way. Nutrition is everything working together within the cell, and then we started, I think, more broadly, and you could argue this case all the way up to whole people and whole societies. That's what we're left with today. We have a system that, in my view, as a researcher in this case, has actually ended up focusing primarily on specific explanations, specific causes, specific treatments. That's the foundation, quite frankly, of the entire pharmaceutical approach. That was another field I had my foot in that community too. And so I had to kind of choose. The nutrition approach, in my way of seeing it at the time, was far more effective. Unfortunately, we got left with in the practice of medicine, I would argue, but also in my community of research, studying one nutrient at a time, one mechanism, so forth and so on. And so it's a bifurcation of thought, starting, as I say, the late 1700s, actually. So nutrition got left out because it represented the constitutional nature of disease. It got left out. And today it's never been included because the field of medicine is primarily focused on one cause, one mechanism at a time. No room for nutrition. In my estimation, looking at the history of the evolution of clinical medicine, that was intended. There was no intent to go beyond the idea, hey, this is local, this is specific. We work with this chemical, this event, that disease. We fractionate disease in all of its bit parts, like cancer, for example. There's 100 different cancers, some would say. I don't agree, but in any case, that's the paradigm within which we live. And really, I see it every time I turn around, whether I'm looking at things physiologically, biochemically, pathologically, you name it, pharmacologically. That is, it was, as I say, I'm still today really impressed with that idea. So my favorite science, nutritional science, has been left out of the equation, left out of the discussion. And there's all kinds of things that feed into that. I mean, the reductionist point of view makes money. The holistic point of view leads to health. Goes right to the source of how food works. That's probably enough. If you let me go, Scott, I'd run forever, but I won't do that.
No, thank you, Colin. That's a great historical perspective. It's always important, to start with that historical perspective. And just to clarify something, someone had asked if I had said live cell medicine, and I must have misspoken. I said lifestyle medicine. I have a little frog in my throat, so I apologize, but it's lifestyle medicine, not live cell medicine. So Kim, if you're able to, do you want to expound on that, that idea of reductionism and kind of where we are right now in the area of research and healthcare? Because I think that, based on what Colin's saying and our experience, we all know that, healthcare has really reductionistically focused on single solutions for diseases, but, we've really not accomplished a great deal in preventing and suspending, in many cases, reversing diseases because we're not looking through holistic lenses. So maybe if you could just expound on the idea, Kim, of where we are now and how this reductionistic approach has impacted research.
Well, if we could just add a little bit of historical perspective and for cardiology, really modern cardiology started with little bits of pieces in the 1800s and 1900s, but it really took off in the United States and around the world when President Eisenhower had a heart attack in the 50s. And all of a sudden, there was a lot more money and a lot more research and a lot more attention being paid to the heart attacks and what the causes were. With that, we found out about plaque, and we had about, ruptured plaque. And then we started finding ways to improve things. The problem is we were all about treatment, and we were not very much about prevention. And so the nutritional aspects were largely ignored, until relatively recent, and T. Colin Campbell and Caldwell Esselstyn, and you can name Dean Ornish, the handful of people who actually led to the understanding that nutrition is the underlying problem. And if we address that problem, then we don't have to deal with all of the other issues. So in cardiology, we have, depending on how you look at it, we've saved a lot of lives. It was a 40-year period of about a 70% decrease in cardiovascular mortality. However, that plateaued in about 2015, and it's gone up a little bit ever since, because we were not dealing with the primary cause. We were dealing with treating the end stage disease. So, where do we need to be? Where are we now? There is a recognition that preventive medicines, and we have societies, and every society that deals in cardiology has a prevention side to it. And we're very active in nutrition, particularly at the American College of Cardiology, trying to get people to understand that they can prevent a wide variety of diseases. And that's one of the best side effects of being the journal editor, is that it makes me step out of cardiology and realize that nutrition affects a wide variety of diseases, not just the number one killer of Americans. So at this point, what we really need is to get all of our guidelines for all of our medical societies, for all of the disease states, to recognize the importance of nutrition and lifestyle in general, including exercise. And this is something that is doable. It's happening, but it's happening gradually when we're in a crisis mode, and gradual just doesn't seem to be satisfying. The dual pandemic of heart disease and COVID makes it even more acute, because we get literature after literature talking about the mechanisms for heart disease and COVID being so similar: hypertension, diabetes, high cholesterol. And to the extent that we have a co-occurrence of risk factors for a bad outcome, we really need to address the underlying causes, and that pretty much is nutrition and lifestyle. So we need to get the word out. We maybe thought we were over it, but now we're going to need booster shots, and we have a Delta variant, and we have to deal with the fact that this virus is going to mutate. But the underlying nutritional aspects that lead to bad outcomes are still going to be with us. So I'm hoping that everybody takes this very seriously, that the recognition that came out of Neil Barnard, for example, has got to throw a shout out to him. Within a month of the pandemic, their organization sent out from the earliest hint that hypertension, obesity were two of the issues that led to bad COVID outcomes. He sent out a note to everyone saying, we need to fix the nutrition. If people had paid attention back in April of 2020, there would have been a whole lot of less deaths around the world. But people kept doing what they were doing. And actually, in many cases, they did it worse because of the isolation. And the COVID-15, not a different virus, but the 15 pounds that people were gaining, it became putting them at even more risk for a bad outcome, because this virus loves adipocytes. And the juicier they are, the higher the viral load that the patient ends up getting. So I think it's urgent that we focus on nutrition and try to make sure that this happens in an organized way. And IJDRP is here to help along. We've gotten a lot of studies. We're sort of I would say in the last 2 months, the number of submissions has risen dramatically. And a lot of them are still case reports and editorials, but there's a lot more original science than there was before. And we're hoping that continues because we can really make a difference.
Thank you, Kim. Thank you. And a follow-up question, I guess, to both of you is, we know that historically we chose the wrong path in healthcare, but it also affected research. And so, of those 1.8 million articles that are published every year, an infinitesimal amount of those articles are really focused on holistic solutions, lifestyle medicine, plant-based nutrition. There are more now, when we go on and you go to PubMed or Google Scholar, there are more articles to review, but not the number of articles, not the quality of articles, and perhaps not the focus of the research that really needs to kind of evolve in order to start affecting guidelines and decision-making in healthcare. So, perhaps, we can continue then with that. The follow-up question is, what do we need to do? What types of studies still need to be completed? What are some areas that we should be focusing on in research? What types of study designs need to be considered in order to move this movement forward of lifestyle medicine and plant-based nutrition? Colin,
So
do you
if
want to
I-
start?
Oh, that's okay.
Oh, go ahead, Kim.
Well, if I could,
Go
just
ahead.
it's because my time might be limited here in the next few minutes, but what I would say is the thing that moves guidelines have been ACC, American College of Cardiology, American Heart Association guidelines 4 different times, and the mood in the room is always the same. We want prospective randomized trials to make a level 1 recommendation. Without them, there's going to be a level 2 and a level of disbelief that what you're saying is an association and not true cause, and that our studies end up being considered descriptive rather than prescriptive. And that limitation, the only way we can deal with it is prospective randomized trial that follow the Institute of Medicine's request of having 50 people in each group or more. And that should be our baseline trial design. What do we need? We need more of the Dean Ornish type of do an intervention and see what happens to the coronary disease. We need stroke. We need every aspect of atherosclerosis to be evaluated with medication, with nutrition intervention, and every underlying risk factor. Some of this has been done, but usually not in large enough amounts. And what we have is some wonderful studies that I have deep respect for because they're prospective. They're non-randomized though. And so if you have 30-year outcomes, there's a way in which, in my mind, that's superior data. But you can never refute the argument, like for the Adventist health studies, that the vegans have lower blood pressure, lower diabetes, lower body mass index, and longer lives. Well, they'll say that, oh, that's a healthy user bias. That is, the vegans are more careful about a variety of things. And unless you do a prospective randomized trial, you don't know that this is real. There's only one way to refute that, and that is prospective randomized trials that are large enough and definitive enough. And there's every aspect of medicine should have those kinds of prevention trials going on. And, the hard part for most of us is actually, having people in a placebo group, or, when I do a church intervention, I make people vegan for 5 weeks, to have a control group, which I never want to do. They're going to eat the baseline diet that we know is destructive, but we can't prove it unless we actually do that intervention. So it's never easy, and the arguments against it, I think Dean Ornish makes the best argument against it when he has a JAMA publication, but it has 6 and 7 people in each group, but it reaches statistical significance. He says, well, it's already proven, but if it's not accepted, the proof isn't as useful as it would be as if it was accepted, and that's where we need larger studies.
Great, thanks. Thank you, Kim. Colin?
Yeah, I been in research and also favoring the idea of the holist concept, for nutrition. I've long heard and understood and accepted the idea that a randomized controlled trial is the bottom line, is the central place to go. We're getting real, impressive data, if you will, convincing data. However, I want to call attention to the fact that given the definition of nutrition, there is some shortcoming in my mind to the randomized controlled trial. Namely, and I think Dr. Williams just referred to that in a sense, and that is that if we have to randomize people, a great idea. We've got people in a couple of different groups of controlled treatment, maybe more than one treatment group. But in any case, we've got these people, we assign them to the, let's say in this case, the diet. And Kim just mentioned the shortcoming of that. Namely, you can't keep people going along and eating the wrong diet, the unhealthy diet, just for the purpose of seeking a comparison. And so they're not going to stick with it. Or people, for example, who have to eat just exactly the kind of diet we want to do, and then have an adequate number of people, sticking to their protocol, not switching around and drifting away. It's almost an impossible task, in my view, because our choice to eat food is very personal. We all know that, and especially when it comes to the rather striking difference between, let's say, a plant-based diet on one hand as opposed to a meat-based diet on the other, doesn't quite work. it really doesn't work. And so that for me, and as far as causation is concerned, that sounds like the best solution for causation, because we're looking for specific effects of specific agents, et cetera, et cetera, et cetera. But I would also argue to know the mechanism by which it works, together with a variety of other kinds of studies, disease trend studies, observational studies. People argue that, correlation doesn't equal causation. Fair enough, that's true. But that's when we're presuming that the cause is something very specific. And when we use these observational studies, there's a million different possibilities, and it's really hard to focus on one just because there's a correlation to assign causality to it. It doesn't work that way. So we have that difficulty. And I think we're going to have to go back to the basics and really think a little bit about the philosophy of the different kind of study designs, and then use them appropriately, and not just rely on only the randomized controlled trial, because that is meant for the use of single agents. You take a placebo, you have the treatment, a pill and versus placebo kind of thing. Simple enough. I mean, that makes eminent sense, architecture, study design wise. But as far as the others concerned, it's troublesome. And my own son, Tom, who's a physician, as you know, just recently published a paper on chronic kidney disease. It was a case study, and I know case studies are becoming quite popular, because in that case, you can take one person, at least one person, and follow them through, and they're willing to do whatever they have to do. You're intervening. And he got fantastic results. It was published in British Medical Journal and was said to be the most sought after article at the time it came out. But that's a whole diet. It's allowing the whole diet to do a special thing. And this guy was a 69-year-old male with advanced chronic kidney disease, about to go into dialysis treatment. And he came off of that, got rid of his drugs, and there it was. He was just the kind of thing we tend to see in the other like cardiovascular disease and some of those as well. So I think we're going to have to really look seriously at the kind of research is done. And the randomized controlled trial does not lend itself to the testing of a whole food diet, and then have people stay on that diet, whether they like it or not. Doesn't work. It just simply doesn't work.
Yeah, you're right, Colin. That is one of the challenges that we face. As Kim mentioned, medicine looks to the randomized controlled placebo trial as the gold standard, and based upon those results, classifies it as level 1 evidence, which directs guidelines. But many of the things that we do as clinicians on a daily basis, like the case study that your son Tom had published, those are more lifestyle interventions that also require an element of behavior change, and that's difficult to capture in an RCT. And so I think you're right that we need a spectrum of evidence, when appropriate, RCTs, but also, as you mentioned, the other studies are also important in the decision making and helping to elucidate the benefits of a whole food plant-based diet and a lifestyle intervention. I have a question here for both you and Dr. Williams, if Dr. Williams is available. So I'll let you lead out, Colin, and then we'll see if Kim is available. Renee asked this question: is there research already available that shows how to facilitate behavior change with respect to moving towards a more plant-based diet? I get shut down by many patients as soon as I suggest giving up animal products. Kind of the backup question to this: is there research that increasing plants in the diet is helpful if one does not become fully whole food plant-based? So I think you can start that, Colin. Is there behavior change research, and is there also research that indicates that even though you may not be fully whole food plant-based, there's still benefit in reducing disease incidence, prevention, and perhaps even suspending disease?
Yeah, as far as the first question you were asking, whether there's behavioral research that we can speak about, Quite frankly, I'm not aware, to be honest about it, of any particularly impressive research on that that's already been published. Although I have heard, of course, as I'm sure you have, Scott, too, this question has been raised numerous times. And there's sort of a lot of anecdotal experience at the present time to sort of address that question. And one thought, you correct me on this, Scott, I'd like your comments on this. There's one thought that I hear from my clinician friends, namely, and I've seen it almost personally, quite frankly, when a person is asked to, let's say, eat just a total 100%, plant-based diet, a lot of people will do it for a week or two, or maybe 10 days at least, or something like that. And they'll do it fairly well as long as things are organized the proper way. But then they slip off. And for various and sundry reasons. There's one thought I think that everybody should keep in mind at the very beginning, at the onset of such a study. That's the fact that if we give ourselves at least a month, and this is why I'm curious about your experience on this, Scott. If we ask people to take at least a month, in some cases, we're going to maybe require 2 or 3. Within that period of time, for a lot of folks, their taste preferences change. They really change. And so they finally get to a point where, they crave a salad instead of the filet mignon. I mean, in the beginning, that wouldn't have occurred to them. And that's the problem with some of these behavioral studies. They don't go long enough to allow for this kind of phenomenon to exist. That's not going to solve the question for a lot of people, maybe, but there's a lot of people who come on board if they stayed with it long enough to really actually notice the changes in taste. As far as, doing 100% versus something less, 60, 70, 80%, is there benefit, in going partially? That brings up a fundamental question in science, and that is basically, I don't like to think of black and white answers. In other words, everybody has to do it 100% of the time, for 100% of the people, 100% of the cases. That's not going to really happen, because I like to think of that question in the context of, do we have evidence that everyone has to do 100%, 100% of the time for all the 100% conditions? No, we don't. I mean, as a scientist, I'm well aware of that. That we can go to the literature, we can't find that kind of proof that everybody's going to see exactly that same kind of benefit. So for me, it's all about odds. It's all about odds. If we get 90% of the way there, there's going to be a considerable benefit, I think. There's a lot of circumstantial evidence to suggest that's true. Maybe 95% may be better. My idea, rather than talking about some edict or command that everybody should be 100% in order to see the benefit, I would prefer to say, here's the goal. Based on the science that I'm familiar with and the totality of the science, based on the totality of the science, I would suggest that the goal is 100%. And because I don't see anything wrong with it. I see a lot right with it. And the closer we get to it, we have some pretty good evidence to suggest that's likely to be true. So I'm saying that's my goal. And everybody should proceed, according to their own preferences, obviously, or their own practices. But the closer they get to it, and I think it's a safe statement to make, the closer they get to it, the more they're going to see the benefits. It's that simple. And along the way, they're going to pick up some new taste preferences. So you're kind of thinking about this question a little bit differently than sometimes it's asked.
No, that's great. Thank you, Colin. Thank you. Kim, did you have anything to add if you're available?
I think he answered pretty well. I just would add that we do struggle outside of in cardiology with prevention more than when it's primary than when it's secondary. That is, if I can talk to a patient and let them know that the heart attack that they had is because they have a blocked artery, and actually try to let them answer the questions, that the blockage is made out of plaque, that the plaque is made out of cholesterol and fat, and that, which means that it came from their diet, they ate this disease. That little string of connecting the dots has been very exceptionally successful in getting people to change their behavior. But having that conversation with them requires that they're admitted to my service or they're coming to my clinic. And I'm hoping that we can get that kind of word around so that people will have the impetus to do behavioral change. But I think that's only the tip of the iceberg. That's secondary prevention. That is after the fact, after somebody is motivated because they've had a heart attack or a stroke or bypass surgery or a stent. Why can't we do more in the behavioral area to motivate people to do this because they're going to improve their health before the bad things happen? And I think that's where the struggle is. And I think that's it's the most appropriate question for the night for the population.
Right. Yeah. And as I've thought through this for, many of my patients, and then, doing immersions at churches, and also talking with populations of people that are not sick, I found that the populations of people that are most resistant to change are those that don't have a problem. They don't have a compelling why to make a change. And so convincing them can be very difficult. That's why one of the benefits we've seen at the immersion is that opportunity to experience something over the course of a week, and that experience of not feeling well and then feeling well at the end of the week. That experiential opportunity really helps to kind of turn a light bulb on. They flip a switch by the end of the week, and they'll often say, I didn't know I could feel this good. I haven't felt this good since I was 18 years old. They didn't know they were actually feeling bad. They didn't know they had chronic inflammation and maybe neuroinflammation because they were just getting by. But the experience of, a week, beginning of week without, without a whole food plant-based diet, not feeling well, end of the week, whole food plant-based diet and feeling better does make a big difference. And I'll just add that, in working with patients over 18 years now, I really found you just have to meet them where they are. And, we don't have to convince them in the first meeting. We give them just enough salt to make them thirsty. And I always know that they're going to come back and see me in 2 to 4 weeks, and I can continue the conversation. And so I'll take whatever they're willing to give me, whether it's adding one piece of fruit or one salad a day, I'll take it. And then I'll talk to them next week and, help move them down the ice toward the goal of increasing their diet, like you said, Colin, to, the whole food plant-based diet level that we know reverses disease. And so, some of this is patience and working with behavior change. And to your point, Colin, I think that's one of the challenges with research, is that if we have a research study that's 2 to 4 weeks long, looking at behavior change, it may take people 4 to 6 months to finally, work through some of the challenges of making a lifestyle change, developing a new community, finding support, working through friction within their family, working on food addictions and cravings and stress and all these other issues that are impacting their food choices in order to really engage in a lifestyle change. And that's not represented very well in a short-term study. So behavior changes, I think that's the secret sauce of lifestyle medicine, whole food plant-based nutrition, primary, secondary prevention. It's really in behavior change, and we do need more well-done research and well-thought-out research to help us understand all of those elements and find some clear pathways forward. And I'll just invite anybody else, if you have questions, please feel free to write your questions in the Q&A window at the bottom of the window there. So feel free to ask any questions, and we'll get those up before the evening's over. So Colin and Kim, thinking about behavior change, because I believe that's something that we don't talk enough about. All of us, me included, love the science. I love the detail. I enjoy discovering the cellular mechanisms that are impacted by, phytochemicals and plant-based nutrition and lifestyle intervention. But at the end of the day, it's the person in their environment, in a culture, fast-paced, stressed, that's making choices. And so the behavior change is really a critical element. And do you have any pearls that you've learned along the way, whether it's from research or your own studies that about behavior change that you'd like to share with our audience?
Well, I'd make a comment, and then maybe it's an opportunity to make a comment in a sense. being in research, I also been in policy development at fairly senior levels for quite intensively for quite a number of years. And one of the things I that came away with was a bit of frustration and disappointment because we can know what we know from research, from clinical experience and that sort of thing, but somehow it's not getting translated at the senior level, you know, when we talk about national policy. And so talking about behavior, I want to make these comments, a side comment maybe, but it reflects the difficulty people have, at least for some folks, of making behavior change because they're not hearing enough convincing data told at the highest enough level. So, you know, in policy, we just do a terrible job and have been doing a terrible job in developing, let's say, doctor guidelines and, you know, whether it's coming from the government or whatever. I know that Kim would probably want to comment on this, especially since he's had such success with in the cardiology community. The idea that somehow we've got to get it collectively, you know, as a society, as folks caring for each other, to get this information out there in a format, you know, that really reflects what we really what we've come to know. And, you know, a lot of us can do that, I think, but the problem is at the policy level, too often we have countervailing forces that want to deny this story. And it will come back and even be a little bit proactive in denying it. That doesn't help the public. And when people are thinking about making a change, they somehow are still living in this environment of really toxic information, you know, at large. And so they have ample opportunities to draw on this, that, or something. Oh, it doesn't work. You know, we need to work a little harder in really addressing that question. How do we get people educated, the public as well as those of us in science or in a clinical setting? We need education. And that would help, I would argue, in the behavior change kind of thing at the individual level. If they just knew that the whole community is all of a sudden starting to talk about this, you know, with some enthusiasm and some reliable information. I don't know.
No, you're right, Colin. No, you're absolutely right. And to a large extent, you know, culture got us into this problem.
Yep.
And so culture has to change to help get us out of the problem. We need a shift in culture, a shift in conversation.
Right.
At every level. That's right. You know, we have about 10 minutes left. I really wanted to ask this question of both of you. You know, we have this journal, the International Journal of Disease Reversal and Prevention. We have 20,000 subscribers, you know, growing number of good scientific submissions and an opportunity, I really think, to use the journal to as a tool for, you know, for encouraging more research in science, but also in reaching new people with the information that will help them make better decisions for their patients. And so, you know, the question for both of you is, how do you see, or maybe what would you suggest as some opportunities for the journal going forward to be a better tool in the hands of healthcare providers and scientists?
Well, if I can pipe in on that one. So it's great that everyone understands that this is the reason that we went with open access, so that people would not have to have any cost to get any of the articles. And open access typically charges the authors, and they can charge a substantial amount of money. And we're really trying, we set it up so that we wouldn't do that. Obviously, that requires donation because there are publication costs. And so getting over that barrier is one thing. And then I think what we're doing with social media, we'll continue to expand that so that every time a significant article gets published, that we are out front and letting people know the kinds of things that can help their patients and where they can find the reference material to affect those changes in their patients. So we'll keep at it. And I think those are the keys: open access and social media.
Yeah, and Kim, I just want to publicly recognize all the amazing work that you've done and just tell you how grateful we are that you're the editor-in-chief and recognize the work that you've done to maintain, a high watermark of credibility and scientific integrity with the journal. So I just want to thank you for all the work and the leadership that you've invested into this project.
Thanks, Scott. It takes a village, though. So I really appreciate all the people that have been working with Plantrician Project and help us get this done every day.
I'd like to support that, what you just said, Scott. I think, Dr. Williams, you really created a moment in time, in a sense, at least as far as general discussions about this is concerned. Here's the president, the cardiology, cardiology, as I understand it, for you to come out and make the statement you made at the time and indicate your interest, that was a real step forward. And that's the kind of thing that I think I was referring to before. More people, like Dr. Williams and others who are in positions of influence like that, that the public recognizes as people of influence, to come out and say, what they have come to believe. We need more Dr. Williamses around.
Yeah. Well, yes, that's right. And one of the projects that we're working on at Plantrician Project, we're launching a new effort this year called Plantricionu, and we've received some amazing donations. We're packaging everything that we've ever done, including the journal, all the conference material, onto a platform that we're going to make available for free to every health profession student in the world. And so to your point, Colin, what we're hoping to do is to find all those young Kim Williams out there in medical school, in nursing school, in PA school, in occupational therapy, physical therapy, PAs, wherever they are. We want to find them and we want to give them this information. We want to give them the journal. We want to give them every lecture from both of you at all of our conferences and all of our other amazing speakers. And we also want to set up a mentoring program. It'll probably be next summer, where we can identify young leaders and we can create some mentorship opportunities. So people like ourselves that have been around for a while, we can step in with these young students and mentor them, not only in understanding whole food plant-based nutrition, but mentoring in leadership, in research, and helping them develop their careers at a much more rapid rate so that we can impact education at that beginning level. We don't have to unlearn like so many of us have had to, Kim and I, and then relearn. We can help, educate them from the beginning with a right holistic understanding of nutrition, research, lifestyle medicine, and they can integrate that into their practices from day one. So for all of you that are here and watching, that'll be something you'll see. Hopefully this fall, we'll be launching late fall, Q4, and we'll be asking for mentors and people that would like to be a part of this next year. So you can watch for that. But you're right, Colin, that's exactly what we need to do. We need to find those young Kim Williams, and we need a lot more of them. That's right. We have one more question here. Question is from Adrian. Are there medical apps and websites like UpToDate or WebMD that can post studies or medical influencers? Do either of you know of any apps or websites like UpToDate? Kim?
So the real question is whether or not there's an app that will focus on prevention and prevention research.
I guess it's, yeah.
Yeah, I mean, so I'm not aware of any, but any separate from the American College of Cardiology guideline app, which is very plant-based when you read through the most recent prevention guidelines and hypertension guidelines and lipid guidelines. All three of them focus on nutrition and predominantly plants. Those are actually available on the American College of Cardiology guideline app. But it hits me that this is an opportunity for every lifestyle medicine society to have an app that helps people. There are loads of dietary apps, as you know. There are ones that'll count your calories, and there are ones where you put in, it'll track your food. There's ones where all you have to do is take a picture of your plate and it'll categorize everything for you. So yeah, I think that's an opportunity for the future. And it hits me that there might be room as we expand our reach, as the vision that you presented a few minutes ago, Scott, that perhaps there should be an IJDRP app. So.
Yeah, great idea. That's a great idea. Maybe one of the best ideas that comes out of this. That's right. And, it can link to, there's a couple of sites that I enjoy going to, plantbasedresearch.org, Michaela Carlson's site, where she has categorized, evaluated, vetted, and categorized more than 700 studies. It's a great resource. And then plantbaseddata.org is another one. Our friends in the UK have that one. Those are two great sites, and those would be great resources as well.
And plant-based docs, you're doing that one as well, right?
Plantbaseddocs.com, that's right. .com, right.
Okay.
The follow-up question from Adrian is, how can we get the info to where most of the eyeballs are? So do you see any channels where we can take the research maybe from IJDRP? It's always been one of our visions too, and kind of target that into UpToDate or WebMD or these places where we might get more traditional healthcare providers or colleagues seeing this information. It's a good question.
Yeah, I think it's a good question. I would say that capturing the younger people is what's going to really make the difference. And in that regard, we have focused mostly on Facebook and Twitter, and we probably need to do Instagram and TikTok and everything else. And so expanding our reach on social media would be good. But, the capturing, you do have a wonderful database of emails, and partnering with everyone who can be reached by email would be another opportunity. The interesting part is the number of folks who open there's a sort of email overload. So you kind of have to go through multiple methods and multiple pathways to get people's attention these days.
Yeah, that's right. Thank you, Kim. Thank you. Well, we're at the top of the hour and at the bottom of our questions, so that's a good combination. And I want to respect everybody's time. I just want to thank first our staff, Alexis and Tom, who are here, and for all of their work and for spending time with us this evening, making this happen. Colin, Kim, it's always such an honor to spend time with you. I love our conversations. I always learn something from each of you every time we talk. And I'm so honored to call both of you friends, and respect so much all that you've done. So thank you for taking an hour for us this evening.
Well, I really appreciate, and I always learn from you guys as well, and love to hear that history from Dr. Campbell. And I'm sorry for keeping everyone in the dark, hopefully literally and not figuratively.
Yeah, and thanks, Scott, for your enthusiasm. Every time I see you doing one of these kind of things, you're full of smiles. You really you're into it, and you're a believer. It's very nice.
Yeah, thank you. Thank you so much. I'm really grateful. I also want to just take a minute and especially thank Beth, who is in charge of our development. She has been an amazing addition to our team, and she really spurred this idea of reaching out to those that have supported the journal, creating this evening and this conversation, and she's helped us really pull together some wonderful fundraising initiatives this year that are furthering the journal and the Plantrician Project. So thank you, Beth. Thanks for making this a possibility. And to all of you, thanks for spending some time with us. And if we can ever be of assistance to you at the Plantrician Project, please don't hesitate to reach out. That's why we are here. That's why we started the project, was to support you. And at info@plantricianproject.org, we're always there and always available. And we hope to see you this year at our virtual conference in September. You'll see more information coming out on email in the coming weeks. And we certainly hope that you can join us. In 2022, we will be live together, sitting around a table, having a conference in Palm Springs. And so I very much look forward to that. Virtual has been good. It's given us an opportunity to reach a lot of new people, but there's nothing like sharing a meal and fellowship together and learning together. So we'll look forward to seeing you in 2022. So thanks, Kim. Thanks, Colin. Thanks, everyone. Have a wonderful night.